Over the last month, I've spent over 300 hours in the medical ICU, caring for patients, saving lives, having difficult conversations, and seeing terrible tragedy. These are the 5 most important takeaways that I've gotten over that time period. The first is to have end of life conversations with your family and your loved ones now. Here's the thing. Nobody ever expects their family members to get into the hospital, one, or to get upgraded up to ICU level care. Even if you have family members that are sick, injured, have chronic health conditions, have substance use or something along those lines, nobody ever actually expects to receive a phone call saying your family member is in the intensive care unit and is borderline straddling the edge of life and death. No one expects that. Therefore, nobody's ever prepared to have the conversation. Nobody's asked the important questions of what their family member would want. And in those situations, because there's just so much pressure on particular people to make decisions, everybody handles it differently. Some people clam up, some people essentially just push everybody away. Some people want multiple members of their family or their loved ones asking them for advice and go back and forth as far as what they'd like to do. The core question that I've asked all patients in that situation is, if your family member was with us right now, standing next to us rather than in the bed, intubated, sedated, unable to communicate, what would they want for themselves? Some folks answer that question and say, my family member, my loved one was a fighter. They want to fight to the very end, irrespective of if there's a chance of them coming back or not. Other people say, my family member was really keen on quality of life. If for some reason we were to be able to get them back and they're unable to actually have a good quality of life afterwards, they wouldn't want to do that. And so we can try everything, but if it gets to a point where it seems like the quality of life, even if they were to get out of this, would just be so debilitating that it would be incredibly difficult for them to live back at their baseline or do XYZ thing, then I don't want to do that. Everybody has different, everybody approaches these situations differently. Now, the reason why you should have it sooner rather than later, because in the worst case scenario, family member is intubated, sedated, not communicating, not getting off the vent, has different organs failing, likely will pass, but can't say for sure. And if they were to get over the acute insult, it would take months of physical therapy, occupational therapy, speech therapy. It's a grueling process what to do in those situations. People aren't sure, and it takes a lot of time to process something like this happening. So at the very least, having some idea of what a family member or loved one would want before that situation, God forbid it ever occurs, before that happens, will at least give you as the decision maker the peace of mind to say, okay, I'm not doing this, I'm not holding this person's life in my hands, so to speak. I'm just following their wishes. The second important thing that I've learned from medical ICU is that drugs and alcohol are absolutely terrible. You know, everybody says to use things in moderation, and perhaps for alcohol, I could say that works, but by and large, I would say at least 50% of all the folks that I've seen in the medical ICU have had some problem with alcohol or drugs. And by drugs, like all sorts of drugs, from weed to cocaine to like methamphetamines to all like the drugs themselves, terrible. And the thing is, when I say drugs are terrible, everybody thinks about like the primary organ that a drug affects, right? Like say someone's alcoholic, they think about their liver. Say somebody smokes a lot, they think about their lungs, right? But drugs affect all organs of the body at all times. So somebody can come in with liver failure, and if it's bad enough, then their kidneys also start not functioning, and then they could have damage to their kidneys related to their liver failure. Or their heart needs to work harder, and then they can have heart failure related to the liver failure. Somebody can use cocaine and say, okay, I'm using this cocaine, and then they get strokes in their brain, or a heart attack from the cocaine, or lung injury from a side effect of the cocaine use, right? These are things that folks don't think about at all. Plus, it's not even the organs that get directly affected, but the life around that person gets absolutely destroyed once an addiction begins to build up, and even before that addiction builds up, right? So that's something that struck me so strongly. Like the percentage of folks in the intensive care unit that have some relationship with drugs and alcohol within their life to like a large extent it's baffling. It's really, really sad, and so it's important to be aware of that. And also, when we're talking about the effects of drugs and alcohol, we've mentioned effects on the body, we've mentioned effects on kind of the social situation, but the other thing is, when you have effects on your body and your organs start breaking, it puts you at risk for different types of infections. These are things in the medical field we call opportunistic infections. These are molds, fungi, like molds and fungus, different sorts of weird viruses, different things that you wouldn't necessarily expect, not only that can be throughout the body, but that can also go to the brain and other particular organisms. So it's not even like, oh, I'm doing this drug, it's affecting one part of the body and maybe it could affect multiple parts of the body, but it also puts your entire immune system at risk for increased vulnerability to rare infections that require stronger antibiotics that have worse side effects. So it's like a quadruple whammy. It's really bad. It's something that just struck me as far as things to be aware of. Speaking about dynamics within the medical ICU, one of the dynamics as far as conversations with patients from a physician's side of things and also from patient's side of things is this idea of radical candor. Now, radical candor is a topic that I was blessed enough to have taught to me by the internal medicine program director at UT Southwestern, Dr. Kazi. And it's a core principle of his as a physician that he brings to every patient interaction, where it's from a book. I'll put like a screenshot of the book up somewhere here, but it's essentially think about like a grid where on the x-axis we're talking about how directly someone is challenged by another person, and on the y-axis we're talking about how much that person actually cares, right? Radical candor is when somebody both challenges someone directly but cares about them personally. And from a physician's side of things, especially these days, people are wary about the paternalism that comes from being someone that makes decisions within the healthcare field. This not only happens from the left, but also happens from the right. People don't want to be told what to do. And I understand that, because at the end of the day, it's your body, it's your life, you're the person who's living it. I can only provide like recommendations. If something happens and you're unable to care for yourself, then I can do what is like researched and most medically sound to get you back to a position where you can begin to make those decisions for yourself. But I can't ultimately like force a patient to do something that they don't want to do. But that does not mean that I need to just sit back and allow the patients to do whatever. I don't need to sit back and allow someone to just say whatever, do whatever, act in whatever manner that they would like. Because when someone comes into the hospital, they came to me. You came to the medical team to get treatment. So if you're denying treatment, or you're being rude to the team, or like there's like behavioral issues or something along those lines, as a medical team, I don't have to sit back and just take that. I challenge you directly. I say, hey, what you're doing is wrong from my perspective on this, and this reasons, and I would like for you to stop. And I can say that with firmness and directiveness because I care about you as a person. I'm not trying to belittle you. I'm not trying to look down on you. I'm not trying to do any of that. I want you to live the best life that you possibly can and flourish as well as you can as a human being. That's what I want. I want you to be like the best human that you can be, right? But I also want to make sure that from my perspective as a physician, I'm giving you the most accurate, up-to-date advice and plan and recommendations that I can. And if you go with those recommendations, fantastic. If you don't want those recommendations, then it's my job to ask the hard questions of why don't you want those recommendations? What are the obstacles? What are you thinking? How can we best work together so that we can improve your overall health and well-being? That not only occurs with the patient side of things, but also in the ICU occurs with the family side of things. Because when someone's a family member of another person that's intubated, sedated, it's not conversing or interacting with the outside world, and the physicians come to them and say, the likelihood of your family member getting through this event is very low. Most of the time, people get defensive. They believe that their person is different, that a miracle will happen, that medical team doesn't know what they're talking about. They want a second opinion, all of these sorts of things. From my perspective, that's okay. I understand that processing happens for different people in different ways. And I don't take things personally when emotions start getting directed at people. I prefer them to be more directed at the situation, but if someone directs emotions at me, I don't take it personally because I anchor on the radical candor piece. I care for the family member as someone who is suffering. They're seeing someone that they loved, they grew up with, they've had a life with, in a state of helplessness, in a state that is terrible, that's terrifying, that they could die, and then that's it. That's it. The story is written. They're seeing that person and they don't want to give up on that person. Nobody wants to feel like they've given up. Everybody wants to do the most that they can to provide for the people that they are now responsible for. And that's admirable, and that's important, and that's critical for someone who is the medical power of attorney, someone who's making those medical decisions on behalf of another to have. But on the flip side, from a provider standpoint, I still have to tell the truth. I still need to tell the truth, no matter how painful it may be. I can do my best to be empathetic and frame the truth in particular ways so that it's easier to be digested. I don't want to be so brutally honest that the brutality is such that it prevents another person from accepting the realities of the situation. But I can't lie to the person. I can't fall into ruinous empathy where I skirt around the issue, though I care for them deeply, and then the suffering expounds. And I also don't want to get into the position where I stop caring for them and I become obnoxiously aggressive, or I become manipulative in any type of way, right? And so in the ICU, because of the types of conversations that are had on a daily basis, and the reality that somebody that's in the medical ICU, that's the last step. There's no escalate. There's nowhere you can escalate to unless you're moving them to like a higher and tertiary type of facility. And at UC Southwestern with like we are that spot, right? So there's really nowhere else like in Dallas Fort Worth area, even in the state of Texas, really, that other folks can go to. So we're having these conversations all the time, and anchoring in radical candor is incredibly important for a physician, medical trainee, healthcare worker to have when having conversations with patients, with their families. And it's helpful. Patients' families appreciate the honesty and the care that gets conveyed when someone understands that the person that they're speaking to is there to give them the best advice that they can and support them as best that they can through the situation within reason. The fourth thing that I've learned is teams matter. The vibes of an ICU team matters. Most of the attendees I've worked with were fantastic. People who love to teach, people who were incredibly smart, people who made it easy for other folks on the team to ask questions. If there are attendings that are watching this, for me at least, that's the key thing. I want to be able to ask questions, even questions that are dumb. I mean, I can like Google and research and figure out some stuff and like look at the literature and then come and say, okay, I've looked at the literature, I have this question, and I want to have a conversation for the betterment of the patient. Now, and that goes not only for the attendings, but the seniors on the team, the fellows, everybody should, in my perspective, should be behind the intention to make it easy for other folks to ask questions and to have those questions answered and to engage in discussion. What sucks is when you have somebody who comes on the team and they don't have that mentality where other people, myself, other team members are afraid to ask questions because they're afraid to look stupid, or they're afraid to look dumb, they're afraid to get laughed at, all these sorts of things. Those are the worst, the absolute worst teams that I've been on, and when there is that type of fear, that type of timidity regarding asking questions. And most of the time, if I'm being honest, it comes from the top. I don't know whether it's just like the culture of being pimped, like during medical school training and residency training, getting essentially just filleted verbally by folks above you, and then wanting to pass that sort of trauma on to other people. I'm not sure what it is. There's like a part of me whose heart goes out to those folks, because it's like, wow, so who hurt you? Like literally, who hurt you? It's sad, but I can't say that to them because I'm just like a lowly intern, whatever. But vibes matter. The opposite is when there's a team, everybody's asking questions, people are bringing snacks, music is getting played, people are laughing, people are vibing, something happens, people are saying, okay, how can I help? It makes the day go by faster. It makes it more fun because, I mean, I'm getting there, let's say 6:15. Some people getting there earlier, say 5:45 a.m. And if it's a call day, you're staying up until staying until 7 p.m. or 9 p.m. if it's really bad, and the seniors has like 28-hour shifts. And if you're in a team where it's like, oh my gosh, it's just terrible. I'm gonna have to go in. I'm not gonna say anything, gonna just try to skirt around, try to not get like lambasted by XYZ person above me, try to do my work and dip. That's terrible, that's horrible, that sucks. But if you're going in a team, it's like, okay, it's awesome. This person's going to be there. This person's going to be there. We have some complicated patients, but I have a plan. I'm going to be able to ask questions. I'm going to learn. I'm going to grow. I'm going to have more autonomy. That's great. There's some passion. There's some activity there. And to be honest, when I came into the ICU, I was nervous because, like, again, this is like the last stop. You can't escalate. You can't consult palm for somebody who has a lung injury. You're palm, right? Like, you're the consult service that people hit up like, hey, person's dying, come help us. You feel me? You can't do that when you're at the ICU. So I was nervous, like, okay, how's this gonna work? Like, am I gonna be able to do all the things? Like, am I gonna be able to save these folks' lives when it counts? And I was blessed to have, like, by and large, a great set of seniors, great set of attendings, great set of co-interns, pharmacists, nurses, like respiratory therapists, social workers, case managers. It's really a team sport to take care of somebody, not only medically, but socially, provide them with financial resources, with like mental health resources, all of these sorts of things, physical therapists, occupational therapists, speech therapists, all these sorts of people working together to make magic happen. Like, the final thing that I learned is practice makes permanent. Practice makes permanent. And this is practice on a few different areas. So there's the practice for the, like, studying, right, and understanding the patient, like the actual pathology, the actual disease process, the management and diagnostic strategies. If you see a COPD patient with a COPD exacerbation once and then get asked questions about it, and you can, like, come up with a plan, and then you go down, okay, now you have a template. Another COPD patient comes and you're like, oh, I remember this. I'm supposed to give, like, prednisone 40 to 60 milligrams for 5 days. Okay, great. Boom. Like, oh, opportunistic infections. I guess, like, someone comes in with, like, decompensated cirrhosis. Oh, ascites. Maybe we should get a diagnostic paracentesis on them, and we should probably start them on some sort of broad spectrum antibiotic because they're in shock. Okay, nice. These things start flowing, and the more reps you get, the better it is for you and also for the team. And especially when you have attendings that care about you, care about the team, it makes the whole process work better because call days feel less crazy. Procedures go more smoothly. Everybody gets stuff done better. And not only is it, like, practice when patients come in and understanding like the pathology, the differential diagnosis, diagnostic plan, therapeutic plan, but also practice when you're coming in and you're pre-rounding what to look for, why you're looking for it, how you're looking for it, when you're looking for it, who you're asking questions to, what you're asking questions about, how your physical exam's going, what to monitor, when to monitor it, what to do if something that you're expecting goes wrong, how to, like, think on the fly when, like, you order a chest x-ray, you're going on rounds, chest x-ray comes back, it's completely different from what you anticipated, how to move through these things. Practice makes permanent. The more you practice good skills, then those skills are going to be permanently, like, ingrained into your mind, right? So that's important. Second thing is knowing your why, right? Because it's hard. Like, yeah, you're working 6 days a week, 1 day off, 6 days a week. Like, I thought to myself, well, if God can make heaven and earth in 6 days, I can do ICU rotations and work for 6 days, right? Like, it's difficult. And so if you don't know your why, you can get a little bit wishy-washy. You'll look at your friends, out there, the whole SpongeBob meme, they're out playing, and you're like, oh my gosh, I gotta work again. Oh, geez, this is terrible, right? You start to feel defeated, start to feel like, oh, I'm not cut out for this, start to count the days, count the minutes, count the seconds, start to complain a lot, start to say, oh, woe is me, how terrible this is. All of these sorts of things can come up, and then you become a low performer, you start influencing other people's performances. It's just bad news bears all around, right? So knowing your why is important because in those moments, you say, oh, this is terrible. What's going on? Think about your why. Keep that in your mind. Your higher purpose, your lower purpose, if that's how you swing, right? You like recognizing that, okay? And keeping that in your mind and focusing on that and using that to say, okay, let me just get done. Like, I had this purpose. This is a step towards that purpose. I can get through it because I've got through other stuff before, and just keep pushing. And then finally, just gotta be present. Gotta be present in the moments with people during their hardest times, right? Like sometimes people really need someone to listen. And rather than going into it and saying, okay, I have all these questions, I'm gonna rapid fire at someone, recognize the situation, recognize the moment, saying, okay, I can ask you a question, patients talking, families talking, and they're continuing to talk. Sometimes just sitting back, listening, and they will give you information that will help you care for their loved one in more ways than you would have thought from your limited understanding of their patient, of like the patient in front of you through the medical record or through like what you've seen up until this point. So being present, not only with patients, being present with their families, being present with your colleagues, being present with your attendings, being present with the multidisciplinary team, that's critically important. So those are the 5 biggest takeaways that I've gotten from these last 300 hours in the medical ICU. I hope you've enjoyed it. If you liked it, like the video, share with other folks that you think would benefit, and comment down below your thoughts, any questions that you might have, and other video ideas or topics that you want to learn about, and I'll catch you later. Take care.